Welcome everyone to our February 2022 webinar. This is our free webinar offering that we give every month, and that is made possible by the Alabama Department of Human Resources. So a big thank you to them for making that possible. Today we are so excited, and I'm excited, especially to have one of our own, our board member, Dr. Samantha Hill, will be speaking to us today, and specifically about addressing racial disparities in adolescent sexual health, which is one of our priorities, our policy priorities this year. And so I'm excited to have her speak to us. I know that she has some experience doing this with some graduate students, I believe. And so I know she has some expertise in the area, and just excited to see how she talks to us about this. You probably saw, I am recording this session, so it'll be available to view later. I've already dropped in the chat also the evaluation form for this. Of course, please wait until the end to fill that out, but if I don't drop it in now, I'll forget later. I will try to remember to drop it in again later so that y'all can have it right before we leave. But that feedback is really helpful for us. With that said, I will turn it over to Samantha. Just one more, quick word. Samantha has told me that you can come off mute and ask questions. You can drop questions into the chat. I'll be keeping an eye on the chat, so if I can sort of flag her and let her know if somebody has a question. So feel free to be interactive. And with that, I'm going to turn it over to Dr. Hill.
I'm on mute. Thanks, Christina.
Yes.
Hi, everyone. It is great to be here today. I'm going to talk a little bit about racial disparities in adolescent sexual health. And, just to give you a full picture, so I'm a clinician by training, a pediatrician actually, by training with additional training in teens specifically. I'm also a provider that cares for teenagers and young adults living with HIV. And so I see the gamut of teenage health problems from asthma to STIs, but really, I'm here to kind of hopefully make you guys aware or refresh your memory, for those that might already be aware of some of the things that go on pertaining to sexual health with our teenage population. And so I don't have any disclosures. Right now, all of my funding is through the NIH. I will be presenting at least one thing from an UAB departmental grant. So I wanted to acknowledge them. And then I wanted to acknowledge Dr. Letitia Lopre, and then the HPV You Are the Key to Cancer Prevention campaign, as I've borrowed some of their slides. The objectives today are really, I always start with making sure everybody's on the same page with adolescent growth and development, because it's really hard to understand teens if you're not aware that they aren't older children or younger adult people. And then talk about incidence, which is the amount of diagnoses that occur for different STIs. And in my world, teen pregnancy is also an STI, because ideally we want our teenagers to hold off on starting their families. We'll talk about some strategies to prevent STIs, and then we'll also identify some of the barriers that contribute to disparities, because sometimes when you see this information, if you don't understand the context and the things, the social constructs and all these things that contribute to it, it's easy to kind of put blame on an individual or group of people or things like that. And so it's important that we understand those things. And so just as I said, we'll start off with some growth and development. And there are actually 3 stages to being a teenager. There's early adolescence, which in some cases goes down to 10 or 11 years of age and up to age 14. So those middle school ages. There's middle adolescence, which is 15 to 17 years old. Some people will say 18, but it's really your high school years. And then there's late adolescence and young adult. And this is the period that people forget about often. And these are individuals that might be finished with their primary education. Maybe they're in college, they're in the military, they're being apprentices and interns, but they are still actually teenagers and adolescents. And the reason being is we know our brain does not fully develop, complete development until age 25. And so when we talk about our brain, we're specifically talking about the part up here, which is our frontal cortex. This is the part that really tells us, hey, Samantha, if you do that, you're going to get in trouble. Or, hey, when we talk about young people and not smoking and we say, hey, don't smoke because it's bad for your health, they don't have a frontal lobe that's like an adult. So when they hear that, they're like, okay, what does that mean? That when I'm like 80, which is really old, that something bad's going to happen to me? They think more with their prefrontal lobe, which says, if you say like, hey, don't smoke because your breath will be kicking and no one will want to kiss you, that resonates with them because that's an activity that could happen, you know, tomorrow or in the next hour. And so that prefrontal lobe really deals with time and consequences and all these things, and it doesn't finish developing until 25. It doesn't mean that a 24-year-old is the same as a 14-year-old, but it does mean that even with the most mature 23, 24-year-olds, there's still a little bit of brain development going on. And then, you know, it's important to understand sexual identity and gender identity too. And I didn't focus a lot on this because we were talking about this in the context of racial disparities, but it's also important to understand that as our young people grow and develop, they develop their own sexual identity and in some cases, gender identity, gender expression. And it's really important to understand that sex is something that me as a physician, along with the parents of a child when they're born with, we look at them and we're like, they fit what we think of as a girl or they fit what we think of as a boy. That's a three-way conversation between the doctor and the parents or the NP and the parents. So that's sex. Gender is really this conversation of how that individual, that little baby feels when they get to be older about who they are. Sexual orientation really deals with who you're attracted to in many different ways. And gender expression is really how you express yourself. So I grew up as a tomboy, liked boys, identified as a girl, but my gender expression was more masculine. I was into sports and things like that. I wasn't super masculine, but more masculine than maybe some peers. So that's my gender expression. And it's important to understand that this is always a spectrum. And so no adolescent is like perfect. You might have the girliest of girls or the most masculine of guys, I guess, but even with them, they have some ability to express themselves along the spectrum in any of these categories. And then I always want to make sure that we're on the same page as far as terminology as well. I might be using STDs and STIs interchangeably as we do in society. They both are dealing with things that can be transmitted or given to another person through sexual encounters. So STDs are sexually transmitted diseases, STIs are sexually transmitted infections. They updated the wording to STIs, and the reality is they figured out like, well, all STDs don't necessarily start with an infection, but some do. And so it's just a little nuance. But when you think about STDs or STIs, you can think about gonorrhea, chlamydia, trichomonas, genital herpes, HIV, syphilis. HPV is human papillomavirus, so that's the virus that causes cervical cancer, as well as oral cancers and anal cancers. And then there are actually about 60 different STIs. We only talk about the ones maybe that I've mentioned in that bullet, but there are really about 60 of these things. And then again, in my world, pregnancy is something we kind of lump into that bucket just for the context of teenagers. And so let's start, and I have to move some things around on my screen, but anytime you're interested in kind of learning what young people are doing as far as behaviors, any kind of behavior, so that's substance use, that's bullying, that's TV and social media, that's sexual activity, the CDC, or the Centers for Disease Control and Prevention, they do this survey every other year called the Youth Risk Behavior Surveillance Survey. And with that survey, they basically give it out to high schools around the country. And as long as you have enough responses, your state is included. So for several years, Alabama as a state wasn't included, even though some people did participate because we just didn't have the numbers. But anyway, you can see with this particular data, this is the 2019 data, you can see in the left, there's this column that says ever had sex. And so this is looking at high schoolers that have reported ever having sex. If you look at the traditional green, that's all the way on the far left, that represents the United States. The darker forest green represents white or Caucasian individuals. The lighter green represents Black or African-American individuals. And the yellow green represents Hispanic and Latino individuals. And I always want to make sure I'm inclusive because today we're focusing on particularly disparities affecting Black and Hispanic and Latino, but it's important to know as a group of people that live in Alabama, our Native and Indigenous people are also disproportionately affected with STIs, but their numbers are small and so often are not included in these national surveys. So please don't forget about those populations. But you can see the largest number of, the largest percentage of people that report ever having sex would be our Black, followed by our Hispanic and Latino. And then our white or Caucasian people are actually lower than the national average. You can see that very few young people report ever having sex for the first time before they turn 13, but that number is not zero, that percentage is not zero. That percentage can be anywhere from about 3 to 8%, with African Americans being the highest. As far as having sex with 4 or more people, and so this is a concept that we don't talk about often when we talk about sexual health, and that's the concept of teenagers actually participate in serial monogamy as well as sexual concurrency. And those are fancy terms, but serial monogamy is this idea of, hey, I'm having sex with one person, and then I break up with them, and I'm having sex or dating and having sex with another person. I break up with them, I'm dating and having sex with a third person. I'm not getting tested in between any of these times. So if I eventually get an STI, I have no idea which of those 3 people gave it to me. That's like serial monogamy. Sexual concurrency is something you might have heard less of, but it's actually probably slightly more common. And that's the idea of, maybe I'm having sex with one person, I'm kind of not liking them, but we're still having sex, but now I've met a new person, and now I'm having sex with 2 people. Eventually that first person I stopped having sex with and completely break up with, but there was a period of time where I was actually having sex with more than one person. And so again, if I were tested for an STI and got diagnosed during that time frame, is it person A or is it person B? And I gave you a very short example. Sexual concurrency is actually usually more common with multiple partners. But you can see with individuals that have ever had sex with 4 or more people, our Hispanic Latino have the highest rates at about 13.5%, followed by African American. And then again, our white or Caucasian population is below the national average, as you can see in just about everything except for substance use at the far right. As far as currently sexually active, it's about 1/3 of our young people represented in this graph. And then as far as not using any form of protection for pregnancy prevention, there wasn't enough data for our Hispanic Latino population, but you can see our Black or African American population, about 1/5 of them or 20% of them haven't used anything for pregnancy prevention. So that's either a condom or birth control. And then drank alcohol or used drugs before last sexual encounter, which is it's a huge factor in possibly having sex with someone that you might not have really had sex with if you were sober. You can see that everybody's probably around the same, around 16, 17%. And so then I want to touch a little bit about teen pregnancy, and this is the 2019 data. So it's important to understand, sometimes you hear people say we're improving in one thing or another, and teen pregnancy is the thing I hear this most often in. And people saying we're doing great things in teen pregnancy. And that's true, but you always want to make sure you're understanding, are these great things for all people, or is this great things overall? And so with teen pregnancy, you can see that we have some disparities, and more so with teen birth rates. So there's teen pregnancy, how many teens get pregnant? There's teen birth, how many people actually give birth, right? And so we have the 5th highest teen birth rate among 15 and 19-year-olds in the country. 5th in this case is not a good thing. 5th in this case is a not so good thing. It means we're at the top in the country for having 15 to 19-year-olds become pregnant. And you can see the birth rate there. Most of those are amongst 18 to 19-year-olds. And then almost 20% of those are among people that already have children. So now you're talking about 15, 16, 17, 18, 19-year-olds who are on their 2nd or 3rd or whatever number of child. We have the 11th highest teen pregnancy rate. And so what it's saying is, you know, we kind of almost get to the middle of the United States as far as our teen pregnancy rate, but the majority of our teens that do get pregnant do go on to give birth to their child. That's what that's saying. And the teen pregnancy rate has declined significantly over the past 30 years. And then we are 49th in the rate of decline for teen birth rate. So what that means is that, and I apologize if you hear noises in the background, I have a puppy running around somewhere. What that means is that we've had declines in our teen birth rate, but we are at the bottom. We are almost dead last for actually having declines in that birth rate. We have declines in pregnancy rates, but not birth rates. If you look at the graph on the right, you can specifically look at the teen birth rate, and you can see it broken down by race and ethnicity. And you can see our Hispanic or Latino population actually has had a small increase between the last 20 years for their teen birth rate. And then both of our non-Hispanic white and non-Hispanic Black populations have had some decreases. And so this is another kind of area that we have to focus on. And obviously there are a lot of things that go into not only getting pregnant, but also giving birth. But it's important to acknowledge some of the consequences associated with adolescent pregnancy, because I think sometimes we don't remember that. And so we're not prepared to provide extra support to the young people that do give birth and do end up with children. And so there's a socioeconomic disadvantage. So 60% of teen moms do not finish high school ever. 2% of teen moms finish college by age 30. And then for individuals that have more than one child, they're significantly less likely to return to work or school. And you saw in the previous slide that 16% of the people that actually did give birth were people that had actually had a child already. And so there is that risk for repeat teen pregnancy and birth. There's also a risk for abuse. And what's interesting is, I think myself included, we often think that this is most likely to occur with their partner, but the greatest risk for abuse for a pregnant adolescent is actually their parents. And so that's something that we should be cognizant of, aware of. Do they have the appropriate supports at home? And then you can see the cost economically for individuals who had just waited a couple more years to have a baby. Okay. So now we'll go on to STIs or STDs. So again, these are infections and or diseases that are given through sexual intercourse. And so we'll start with chlamydia. Chlamydia is very common, particularly in young women in general, but there are still disparities or differences in who you might see chlamydia in as far as overall rates. And so I pulled out the Alabama data. So this is data from the Alabama Department of Public Health, and it's from their 2019 data. And so you can see that, again, as I mentioned, females are much more likely to have chlamydia than males. And there's many factors that go into that. One, our young women's rates are gonna be higher because they get screened more often. They're more likely to be engaged in care at this age than our teenage males. And so it's also that question of, if we actually saw males and females engaged in care at the same rates, would this larger number in teen women still be as high? But that's something we'll never be able to answer, at least at this time. But then you can break it down by race and ethnicity. And so you can see, as far as rates of chlamydia, you've got Black women and Black men, and Alabama data is set up a little bit uniquely. So it's often difficult to tease out the age. And so I've given you a little estimate, but you can see that 26% of the chlamydia cases are in Black female, 14% are in Black males. If you compare Black females to white females to Latino females, and again, the numbers are small for Alabama as far as our Native and Indigenous individuals, as well as our Asian, Pacific Islander individuals, you can see that Black females are 26.3 compared to white females at 9.4 and Latinos at 1.6. And then you can see a very similar trend among Black males. With gonorrhea, very similar data. So if you look at the blue, if you're looking at the left figure, and you look at the darker blue, which is at the bottom, that's the 10 to 14-year-olds. And thankfully that is close to the bottom, because those are our early adolescents, if you remember that slide from the beginning. But then when you look at the reddish orange line that has empty circles, those are our 15 to 19-year-olds. And furthermore, when you look at the gray circles, that's our 20 to 24-year-olds. And you can see they're at the top. And why do I lump in 20 to 24 and 15 to 19? Again, when we talk about sex and sexual activity, it's important to know that there's nothing that's concrete. And so you could be, we know that there are laws that say, please don't have sex with someone that's 2+ years older than you or younger than you, right? Because that's illegal. But the reality is, we know that it happens. And sometimes, unfortunately, that contributes to some of the rates that we see. And so for me, it's not a surprise to see our 15 to 19-year-olds and our 20 to 24-year-olds being among the highest groups with gonorrhea, because there's probably maybe an 18 or 19-year-old that is having sex with maybe a 20, 21-year-old or someone in that age range, right? So thinking about it from that standpoint, and really when we talk to our young people, whether you're at home as a parent, you're at school and you happen to be that trusted teacher or that trusted school nurse, when you're in the community, or if you're at a healthcare office, it's really important to kind of get to know and build that trust, to kind of learn what our young people are doing. And again, when you look at it broken down by race and ethnicity, you see something very similar that you saw with chlamydia, which is that our Black females and Black males have the highest rates. In this case, it's gonna be Black males higher than Black females. And then you can see then it follows with our white females and Latino females, as well as our white males and Latino males. Syphilis, it's really important that we remember that syphilis is not just a disease that impacts men. As a pediatrician, I can tell you that I didn't really get to see a lot of congenital syphilis, meaning babies born with syphilis, in my training. But when I moved to Alabama, congenital syphilis was something I saw. And so the rates of congenital syphilis, meaning babies born with syphilis to mothers that actually had syphilis during pregnancy, is high in this particular state, amongst other states. And so that means that there are women that live with syphilis too, or that have syphilis that's untreated as well. And so you can see on the left with syphilis, you can see again, there's that blue with the open circle is our 15 and 19-year-olds, and they're kind of towards the bottom and in the middle. But then again, there's that age group that some of them might be interacting with, which is that 20 to 24-year-old age group. And that's that orange diamond that's towards the top and is vying for the #1 spot with the 25 to 29-year-olds. So this group is like all lumped together. Syphilis, you can see the comparison. Again, Black males by far have the highest rates, followed by Black females, followed by white males and then Black females. One of the things when I teach the students I'm with, if you look at syphilis and if you look at HIV, it's really disturbing because you see the rates for white men and for Black females, they're usually very close to each other. Black men are usually, a distance off, and then there's Black females and white males. And we talk about why we think that is. And so it's something to think about. And then you can see the rates for Latino females and Latino males as well. It's important to also understand that syphilis in medicine is what we call the great masquerader. And so syphilis looks like anything. It could be a rash. I've been in a pediatric office and diagnosed someone with syphilis because they had a sore throat. It could be literally anything. And so this is one of the reasons we really talk about recommending your teenagers getting regular sexual health screening. So whether that's getting screening after they have a new partner or they break up with a partner before they start a new relationship, or just having screening every 3 months, because syphilis looks like everything.
Dr. Hill, I have a question about syphilis. So you had mentioned congenital syphilis, so passed on to a baby through birth. Because I have had a baby somewhat recently, and I'm sure that I was tested for STIs in my, prenatal panels. How are those not treated, I guess, ahead of the birth of the baby? Are those women just maybe not getting adequate prenatal care?
So there are a few factors of this. So one could be you're entering care late. And so we know there are cases where maybe someone's had multiple children, and so they're like, I'm good. I know when I'm going to have the baby, and they enter care as they're delivering, right? And that's that precipitous delivery that you might hear that term thrown around. Those are the women that show up, they're about to give birth, and nobody's seen them at all during their prenatal visit. But then there's the bigger issue, which is stigma. And so it's the same with HIV. Syphilis and HIV, for whatever reason, are two infections where sometimes your provider will look at you and be like, Christina, you're a white woman. You seem like you're good people. You know what, Samantha, you're a doctor and you're Black. You're not doing anything crazy, right? Because their perception of what it takes to get an STI is like, you have to do all these amazing things. And so they're not screening you. They're not offering you the screening. If you don't know to ask for the screening, it's not getting done. And so I can give you an example for myself going through training. Oftentimes, regardless of what I'm doing in my personal life, I make it a habit to say, are you going to test me for STIs today? Because I just want to see what my doctor's going to say. And more times than not, my doctor's like, well, no, you're good. I mean, do you need to be tested for STIs? Because they've made an assumption, as opposed to thinking about Christina's in her 3rd trimester. Have we checked her to make sure that she doesn't have syphilis or HIV before she gives birth?
So I mean, my assumption was that I had been screened, but there's a chance that I hadn't been.
There's a chance that you haven't been. And so, depending on where you are in the country, what hospital system you're in, and the biases of the providers that are on your team, they should be following a protocol. And if they're following the protocol, you've been screened. But sometimes, and usually it's more of an individual. So it's not like this team B is all like, oh my gosh, we can't tell people that we're screening them for syphilis, and we can't screen them for syphilis, so let's just not do it. But usually there might be a person on the team, and what they want to do is be like, hey, by the way, Christina, we're going to check you for these STIs like we normally do. And there's a bias about them that you might think of them a certain way, you might get mad. all these different things. And that prompts them to be like, you know what, never mind. I'm pretty sure Christina doesn't have syphilis, or I'm pretty sure Christina doesn't have HIV.
Gotcha.
We're okay.
Okay.
That's a great question.
I have one more, just because you mentioned it. So you mentioned that Black females and white males are always sort of like right next to each other in these STI cases. Why? So I am curious, like, why is that? I wouldn't have thought to ask that question until you just mentioned it.
Yeah, and the real reason is it's so complicated, and we still have a lot of work to do to understand. But one of the simpler explanations is we haven't really been focusing a lot on Black women for a while. So we do a lot of focusing on what the category that they call is in research is men who have sex with men, or same gender loving, gay or bisexual men. There's a lot of research, regardless of race, on that particular group. But what we're learning more, and what communities have been trying to tell us probably for decades, is that sex is definitely more complicated from that, and who we choose to have sex with is more complicated than that. And so there's this group, in this case, Black women, and because we never quite understood who they're having sex with and why they're having sex with that person, we're starting to now realize we need to do more understanding of that. There are, I don't know, it's hard to explain, because it's hard to explain because the data is not completely there, and it's hard to explain because the way people want to shape the data is to blame it on a specific group, and I don't even want to put that out there because it's not on the group. It's really about people living their lives, and us on the service end, people that are providing the services and information, having to step up and do better at doing education to empower particularly Black women, but all people, to care for their sexual health, if that makes sense.
Okay, so I think what I'm gathering is it's about behavior. It's more about the behaviors that are taking place, and not about the different labels that we're maybe putting on people.
And that's the perfect way to say it, Christina. When I teach the students and residents, I'm like, you and my label, like, what if we label someone gay, if we label someone straight, that's a label. That doesn't describe their behavior. We think it describes their behavior, but people are so much more complex than that.
Right. Okay.
So that's perfect.
Okay, great. Thanks for clarifying all that.
No problem. And then, so HIV is a continued concern. I will say, within adolescents in general, there has been a decline in HIV throughout the country over the last decade or so. But when we look at the South, and you can see the South here, the darker the colors, the higher the incidence for HIV, which means the higher the rate of new diagnoses for HIV. Let me see what the shot is. Yeah, so before I continue with HIV, Valerie is mentioning that in her experience, because she is labeled, again, a single woman, she was listed as high risk by her provider, and that she was upset because they automatically assumed that she was sexually active or was engaging in some higher risk behaviors. And so she asked them, she saw that probably as a diagnosis in her portal, and she made them change that, which I think is awesome. And then you have to be aware, like she's saying, you have to advocate for yourself. You have to be aware of what the providers are noting in your charts, and that's perfect. And sadly for our teenagers, like, I can speak to the hospital I work at, unless their parents or the teenager think to do differently, the parents usually have access to their entire chart, whether the parents look at it or not. And so you really have to, it's all about advocacy, which all of us can do regardless of, whether we're a parent, whether we're the provider, or we're anything, we can do that. So HIV in adolescents. And so as I was mentioning, you can see that in the Deep South, you can see that the rates are really high, as well as in some places on the West Coast, as well as in the Northeast. The highest rates for HIV, period, are DC. They've always been DC, they're DC, Washington, DC. But the South, and particularly Alabama, continues to have high rates. Alabama was named by our former President Trump as one of the hot spots in the country, one of the 8 states that have a hot spot for HIV, because the amount of diagnosis we have among rural populations is way out of proportion than what it should be based on how many people we have in our state. And so because of that, we get all this money and information to help with HIV. And so that you can see, there's 2 ways to look at HIV. You can look at the people that are living with it, and that's called prevalence. So that's the idea of you have HIV and you're added to this large bucket of people that have HIV. So that's prevalence. And that bucket you don't exit that bucket until you pass away. So that's prevalence. And so you can see that the prevalence, or that first set of columns on the left of this figure, for people that are between 13 and 24 living with HIV is low, right? So it's less than 5%, whether you're talking about the Southeast US or Alabama, that's slightly higher. Then you've got this bucket called incidence, and this is the incidence bucket. Incidence is how many new diagnoses are occurring in a specific period of time. And so you can see that the incidence is much higher, both for the southern US as well as for Alabama, who's almost 10 points higher than the southern US. And the thing is, with the incidence, these diagnoses get added to this bucket. So if we don't do something about adolescent diagnoses of HIV, eventually this prevalence bucket will start to get higher and higher and higher. And so just keep that in mind. And I see a message in the chat from Elizabeth. When I was pregnant with my daughter, I was low income due to the closure of my business. I was tested for all kinds of STDs compared to when I had my son years before and my business was thriving. None of those tests were performed. And so that's a great point back to Christina's question, which was, you are your own case study. You saw yourself when you had a business that was thriving, and you saw yourself when your business wasn't thriving, and you saw the difference. And you noted that none of those tests were performed when you were thriving, because someone made the assumption like, oh, Elizabeth's not gonna have any STs. And that's how we miss things. Those are our biases, which all of us normally have. We all have biases, but when our biases impact the care or the information or the provision of services that we provide, that's when you start to see disparities or differences in health. Let's see. Okay, so and I keep having like all my things. Okay, so this is looking at the rate of newly diagnosed cases for HIV based off of race and ethnicity and sex. And this is that incidence word again. And so you can see they split it up over here, and you've got colors of red, orange, and blue as far as male, female, and total. And again, you see for Black men are the highest. Then look, there's Black women in this, and the way they've broken it up, white men aren't even close. And then let's see, you got multiracial that's kind of approaching it. Hispanic is there, and they're kind of on par with Hispanic males are kind of on par with white males, and then Hispanic women are a little bit higher than white males. Other and unknown is where they kind of group everybody else, and you can see that there. In 2019, you can see that the rate for HIV diagnoses among Black males was 8 times higher than the rate among white males. Looks like I'm typo. But then the rate in Black women's was 9 times higher than the rate in white females. And so it's really important to understand that. HIV incidence among Blacks is about 3 times the total of the state rate, right? You look at this, the state rate is at 21, and then you look at Black males right here, way high, right? And so it's important to understand that these numbers can change. These numbers can change as we do things, as we empower communities, all of these numbers. So we could eventually get all of these numbers to be somewhere like the white women and the other unknown women down here that are super low. We just have to start doing some stuff about it. So as I mentioned at the beginning, I actually am a person that provides care to young people living with HIV. That was actually my passion, and believe it or not, that's why I got into pediatrics. You don't hear many pediatricians going into pediatrics. 1, to work with teenagers, and 2, to work with teenagers that live with HIV. But that was my goal. I do a lot of things, but that was like my goal because I saw it growing up. I'm from Atlanta, for those that don't know. And so what I looked at is I just took a time range, January 2019 through May 2021. So it's like a year and a half. And we had 75 new people between the ages of 13 to 21 diagnosed with HIV during that year and a half. 75 new people. Of those 75 new people, 12 of them were between 13 and 18. These are your high school kids. So 12 of those kids were between there. 16 were in the 19 to 21-year-old range. So that's kind of college, but we know college goes into this range as well. And then most of them were 22 and older. If you look at it and you break it down by even by gender, you can see that most of them were 19 and above as far as for women. But when you look at Black women, all of the people that were diagnosed with HIV in that time range that were between 19 and 21 were Black, and all but 2 among 22 to 30-year-olds were Black. And so you can see the disparity there in that. And then I wanted to throw on HPV, because we don't talk about HPV a lot. We don't talk about pregnancy, and we don't talk about HPV a lot. And so HPV is human papillomavirus. It is a virus that you can get as a young person, but you won't necessarily see the effects of it until you are 50, 60 years old. And we'll talk about the vaccine later. But you can see there's disparities there as well. And so you can see when you look at white versus Black, the rates are the same, which is nice, but they're higher than American Indian, Alaska Native, and Asian Pacific Islander. And then they're right on par with, almost on par with our Hispanic population. And so you can kind of see that as well. And so before we go any further about what we can do about this, it's important to know that there are a lot of things that lead to disparities in health. And I always start with social determinants of health. And so social determinants of health is really this fancy term for it's where we live, it's where we work, it's where we play. It's all of these things that kind of impact our day-to-day, our family's day-to-day, and what we're exposed to. And so it deals with like where you or your parents are employed if you're a child, you know, and how much financial resources you have. It's when we talk about, you know, like, do you have a neighborhood that's safe for you to go and walk around in? Because I'm trying to tell you to go walk around to lose weight, but you can't walk around if there are gunshots going off everywhere, right? That's part of a social determinant of health. It's education. Did you have access to education? I went to a middle school where they had nobody to teach math. Every teacher that they had, they were forced them to just read out of the math book. So it's amazing that I had no any math at all. But I didn't have a math teacher in middle school at all. I just had the book. Food, you know, did you have access to a variety of foods, fruits and vegetables, food that was free from contamination? I trained in Delaware, where a lot of the people that grew up there were exposed to some of the chemicals put out by this large company in their soil, and that impacted food as well. And there's high rates of cancer in that area where I trained, specifically because of that pollution. And that's regardless of kind of like what your income is. What kind of community did you have access to? Was it a variety of different populations and races and ethnicities? Did you grow up listening to a variety of different languages? Were you only exposed to people that were like you? Were you exposed to seeing maybe trauma either placed upon you by your parents, or your parents placing trauma on themselves, or things like that? Did you have access to healthcare? Were you able to go somewhere and get checkups? Did you just go somewhere and get your vaccines? Did your parents have the ability to take off when you got sick? Mine didn't. When I got sick, I was told, you're fine, go to school. If I got injured playing basketball or ballet, you're fine, go to school. And then the one that is a plus minus, depending on how old or new the literature you're reviewing, are these systemic things. And I've listed systemic racism because we're talking about racial disparities. But these are also sexism, homophobia, transphobia, xenophobia. These are all the systemic oppressive things. And that's another social determinant of health. And all of these things, if you can see, they affect your health and well-being. And so it's important to understand that when we talk about STIs and STDs, because when we think about barriers specific to Alabamians, as far as why we might be seeing the numbers that we see in general, let alone in certain populations, we think about healthcare coverage. And we think about, you know, if we were to have broken some of this data down by either income, insurance, we would see that there's a larger proportion, maybe in some people that are uninsured or underinsured. And that goes back to Medicaid expansion. And then you go to access to accurate information about sexual health. Christina will tell you all the time, we're advocating for comprehensive sexual health and education. You know, abstinence, and I'm here to tell you, there are teenagers that are abstinent. I want to make sure that we say that. There are teenagers that are abstinent. But you have to make sure you provide appropriate information so that whether they're abstinent or not, they know what's out there. They know what risks and benefits are in their language that's developmentally appropriate for them, and how they can protect themselves, right? And you want them to get that from you as opposed to Joe on TikTok. There's access, there's differences in access to providers that are willing and able to prescribe certain things, such as birth control, such as PrEP. I have a friend, she lives in a different part of the state. she's very honest. She's like, when a 14-year-old or 15-year-old comes to me for birth control, you know, I don't care what it's for. That's not for me. They need to go to gynecology. You know, and so if they need it for their period, she's like, that's not what I do. They go to gynecology. And so that's a problem. What if gynecology is 2 hours away from you? And then, you know, providers recognizing risk as well as teenagers recognizing their own risk, right? We just talked about in the case of a couple of you guys, you know, when you were pregnant, what happened, sometimes your provider didn't recognize your risk because they didn't ask or they made an assumption. Teenagers do the exact same thing. They assume if you know, you look clean, you look well put together, you probably don't have anything. Nobody's told me that you have anything because of course that's what people are gonna do, you know? And so there's this absence of recognition of risk. And while we're on that, my pet peeve is that risk isn't even the best term. Risk turns people away from what you're saying and wanting to, you know, potentially explore what you are offering, because it's a negative term. And so we really want to advocate for sex positive language, right? So like, you know, if you're gonna have sex, let's see if we can figure out how to make sure that you're doing this in the safest way so that you're having pleasure from it and you're not just worried about getting an STI. Let's see, distance from healthcare settings. So we know we live in a rural state. We also know we live in a state where there's not a lot of public transportation, let alone in specific cities, let alone across the state. And so that can be challenging, having access to a vehicle to get you to transportation. I have patients that come to my HIV clinic, and we've had to have people go and spend the night in their hometown so that they can be there in the morning, pick them up and drive them to clinic. Transportation is a big problem. And then stigma, whether that's, I think I'm Black and so I'm gonna be dirty, or people are gonna assume that I'm dirty, you know, whatever these stigmas are that we have, or if it's a community stigma, you know, don't do anything with birth control because it's gonna take your fertility away. Or if it's the healthcare provider, like, he or she is more likely to do this behavior because they look a certain way or they come from a certain neighborhood. And so those are some of the specific barriers. I didn't even have time to cite this stuff. This is part of what my research is on, as well as a lot of other people that are around the state do research on. And so these are specific barriers to the state, of which many of them are shared throughout other states as well. So what can we do to prevent STIs? And so I put this little graphic on here because I think it's cute. But there are so many tools that we can use. Abstinence is obviously the biggest tool, but again, it doesn't apply to everybody, right? There are some teens that will say, well, I'm gonna be abstinent now that I have an STI, and they're successful. But then there are other teens that say, now I'm gonna be abstinent after having an STI, and they're not successful. And we have to be able to work with both populations. And so comprehensive sexual education, I already mentioned, barrier protections, so that's condoms, that's dental dams, and knowing how to use them and showing people how to use them. I've shown young ladies that have some longer nails how to use them, and I watch them shred it, and I have to teach them how to use it with the fleshy parts of their fingers so that they don't shred the condom as they're putting it on. Pregnancy prevention, so that's birth control. That's also emergency contraception, which I think I might be able to get to. STI prevention, so that's getting tested, whatever your regular testing regimen is. When I meet new people with HIV, when I meet new young people, I'm like, so, you know, what prompted you to go get tested? I'm always excited to hear when they say, well, this was just my regular routine screening. Yes, it sucks that they have HIV, most definitely. But I'm always excited to hear they were someone that always got routine screening, whatever that meant for them. That makes me smile. And then HIV prevention specifically is STI testing, post-exposure prophylaxis, pre-exposure prophylaxis, and then if you are someone living with HIV, adhering to your medication so that you have an undetectable viral load and can't give HIV to anybody.
Dr. Hill, sorry, can you just, I feel like folks may not know what post and pre-exposure prophylaxis are.
Yeah, let me scoot through those then. I can, I have them in here somewhere. There we go. Yes, so let me do so we'll start with the easier one, which is if you're living with HIV, if you take your medicine like you're supposed to and your viral load is below a certain number, and it's been like that for at least 6 months, you actually can't give HIV to anybody. And that's a big important thing to know, because that hopefully will start to reduce some of the stigma. If I get HIV, then my life is over, because that's not true. And so when you see U equals U or undetectable equals untransmittable, that's what they're talking about. Then you've got PrEP, and let me make sure I have PEP on here. Do I have PrEP? Okay, let me talk about PEP first, because I left off my PEP slide. PEP, which is PEP, is post-exposure prophylaxis, or you'll see it as in PEP because that means you weren't at work, like maybe me getting stuck by a patient's needle. It's in PEP. And it's the idea that, you know, maybe something has happened in the last 72 hours. So maybe you had sex with someone whose HIV status you didn't know. Maybe you maybe got a little high, and while you were high on what you normally get high on, you decided to shoot up with some folks too, you know? And so you realize that, oh no, did I really just inject something into myself? I don't normally do that. PEP is something that you can take. It's 2 pills, 1 pill once a day, and the other pill you take twice a day. And you take it for 28 days, and it reduces the chances that if you were exposed to HIV, you get HIV. It's something that we give out, particularly if someone's been sexually assaulted. You'll see that they can get it in the emergency room. That's PEP. PrEP is post-exposure prophylaxis. And so this is the idea that, hey, you know, I know what I'm going to be out here doing, or, you know, maybe I just worry a lot about getting HIV or whatever reason. I want to take something so that my chances of getting HIV are super low. It came out in 2010 as PrEP. It's important to know that the medicine is actually, one of the medicines has been on the market since the 90s, but like the late 90s. But the indication for it to prevent HIV has been here since like 2010, 2011. So it's been around. It's got an approval by the FDA. So that's different than if we think about COVID vaccines, right? Everybody's thinking about FDA approved versus the other term. For when it's got a partial approval.
Emergency,
yes, the emergency use authorization.
Yeah.
Yes. Yes. So this is not that. This is full FDA approved. All these medicines are fully FDA approved. And then it's got a grade A recommendation by the United States Preventative Service Task Force, which is the USPSTF, which basically goes through and thinks about all the things that we should be doing to prevent different diseases and things like that, and it gives them a letter grade from A on down. And so this is an A. This is such an A that it's actually now covered by insurance. It's right, Dane. It's Truvada. Truvada is a brand name. Descovy is a brand name. Apretude is a brand name. So there's 3 versions. And you can see, don't look at the jargon, but Truvada, the one that Dane mentioned, is available for anybody. It doesn't matter what your sex or your gender is. Descovy is really for individuals that are engaging in rectal intercourse, particularly men, and they're working on trying to see if it's effective for women. And then Cabenuva, not Cabenuva, cabotegravir or Apretude is available for everybody as well, and it's an injectable. Truvada and Descovy are pills, and you just take 1 pill once a day. But Apretude or injectable cabotegravir is an injection, and you take it once you get on it, you take it every other month. So every other month you get an injection, and all of these can be used to actually prevent HIV. Who are they for? Basically, the CDC has different recommendations. What you need to know is they're for you if you want them, or your kids or whatever. So these are just guidelines for us to think about who are some people, if they come across our way, that we should be talking about PrEP to. But the reality is, and what I teach my residents is, if someone's asking you about PrEP, they may or may not have disclosed something else on this slide, but you need to consider giving them and offering them PrEP unless they're obviously living with HIV. That's the only contraindication, strict contraindication to these. There are some other things that are way too medical for this talk that I'm happy to talk with people, because this is also what I do for a living, is prescribe PrEP, particularly to younger people when they need it. And so, yes, let's skip that and go to some other things. I do want to talk a little bit about emergency contraception and contraception, because we don't talk about that. But before I want to talk about that, I want to talk about consent. And it's important to know that, you know, people can consent to, young people can consent to some of their medical care. That doesn't mean that they should all the time, because maybe they have a different ability that inhibits their ability to process what you're saying in the most appropriate manner. But sometimes they can actually consent. But you still want to encourage that conversation with their parent or guardian anyway, or with a trusted adult person anyway. And so you can see the consent laws here. Contraception, which is what we use to prevent pregnancy, and with the condom, STIs as well. I throw this on here because it's important. This green patch is where we all live. We either live in the green or we live in whatever this funky color is down here, which is this color down here is like, I'm going to pull out, you know, I'm going to pull out. when people pull out, 12 to 24 out of 100 women can become pregnant anytime you pull out. That's not a very effective mechanism. Condoms are great, but they're great when they're used in combination with some of these things. Also because they prevent STIs. We don't see a lot of young women today talking about diaphragms. And then we do have young women that try and think that they can, look at their fertility and map it out on the calendar. If you have irregular periods, this is not for you. It's also not for you as a teenager, right? Because it's just very hard and challenging to do. A lot of people live in this range here where they're talking about pills and patches and rings and the shot. That's pretty good. 6 to 9 out of 100 women get pregnant. And then here are the options that are the most effective outside of this, because we really don't do this in young people. That's like tying their tubes, guy or girl. We don't do that. But these 4 options are all different things that they are a little bit more invasive, but they last for multiple years and the teenager doesn't have to think about them. And so if you ever have questions about this thing, this is usually what I show parents and it's what I show kids. And sometimes some of my parents that are the biggest proponents of like none of this, when they see this, they're like, oh, let's talk, we'll go home and talk about these. And oftentimes they'll come back with those. So
Dr. Hill, I have another question real quick, because we are talking about racial disparities. Do you see disparities? I don't know if you know of data, but what disparities exist in terms of what youth are using these different forms of birth control?
Yeah, and I'll slide to this, but I don't have the particular racial disparities, but in general, what you see here is you see most people doing the condom and the withdrawal and then followed by the pill and the depot. When we talk about racial disparities, anecdotally, the research we do see and what we see in clinic is a lot of our Black young women are using depot and maybe these 2 over here. When we talk about our Latino women, maybe it's this one, maybe it's this one. And so there are some racial disparities, but yes. I don't have the exact numbers for you today.
No, I appreciate that. Thanks for, even anecdotally, it's interesting to understand.
And in general, most teens are a little apprehensive about these things over here. It's interesting, a lot of new technology is trying to come out with the ring, but if you don't work with teenagers, it's hard to understand that a lot of teenagers, when you talk about our Black and Latino populations, they're not using a tampon. So there's no way they're going to stick a ring in their vagina, which is what the ring does. It's a little circle that you stick up into your vagina and it acts as birth control. It comes out when you want it to come out. It stays in when you need it to stay in. But if you're not using tampons, you're not going to use the ring. And so part of what we have to do overall as a community that's working with these young people is really understand where they are and understand why they are in the place that they're at the place and how can we reach them there.
Well, and I've even heard, and this is again anecdotally, but even some friends in their 30s who may not have children that have care providers who won't give an IUD.
Yes.
Even though that's, that's such old thinking that anybody can get an IUD.
Yes. That Christina, I'm not even get into that because that's a soapbox that I live on. But yes, that is. So yes, you do not have to have already had children to get an IUD. IUDs are safe in teenagers. They're safe in even young people that have developmental challenges. So I see young people all the time that are completely dependent on another caregiver and will be for the rest of their life, and they get an IUD. They're safe. You gotta talk with your doctor, see if it's appropriate for you. But yes, that mindset is very old. Let me see. Let's see. And then emergency contraception. I always want to make sure that it's clear that this is not necessarily something to cause an abortion, because that's where I hear a lot of people talking. Like, if I do emergency contraception, then I'm aborting a fetus. And I know there's a discussion in a realm of what constitutes a fetus, and I'm not going into that at all. Or what constitutes life, I should say. I'm not going into that at all. But if you already have life in there, emergency contraception is not going to do anything for you. It's not. And so it's important to understand that and know that we can make it an option to young people when they need it, if they need it. Let's see here. And so I
wanted to say real quick. I was just going to say to that point of it not being an abortificant, that this is an important note in terms of our advocacy and the work that we do on policy, because a lot of politicians do believe that it is an abortificant. They're not scientists, they're not doctors. This is just their personal belief, maybe what they've heard, and we'll throw it into legislature along with abortions. And that that is scary because this is such an important tool for young people, for anybody who may have had unprotected sex, unexpectedly sexual assault victims. So it's essential contraceptive care. And just to be, I just saw something in the Alabama legislature. It was an anti-abortion bill, but they threw emergency contraception in there. And I was like, oh no, this is not okay, because they're not the same thing.
Yeah. And to be very clear too, there's these items, which this is a specific pill, and that's the only reason the brand name is on there. And you can see the generic name is this one. This is, as you probably recognize, a specific IUD. So there's only one IUD that works in this case. This is Plan B, which maybe many of you are familiar with. You can get a 1-dose or 2-dose, 1 pill, 2 pill version at your pharmacy. And then this is just a regular pack of birth control that can work as, if you take it in a certain way, it can work as emergency contraception. And it's important to know that these items have a time limit. So if you had sex 2 weeks ago, none of these are going to do anything for you. None of them. This is like a 3-day limit. These can be up to a 5-day limit. So it's really important to understand the time frame in which you can use these, just like with PrEP, post-exposure prophylaxis, is very short. And so keep that in mind too. But again, we don't talk about it. So that's why I was trying to be intentional and including it in this talk. And then let me see. I'm going to pause here and see if there are any dying questions. But it's also important to understand there are guidelines about who should be getting tested and when. And so if you look at the far right with HIV, everybody starting at age 13 to 65 should be tested at least once. That doesn't mean you have to test a 13-year-old unless they're sexually active. But maybe if you've got someone that's about to go off to school or the military, go ahead and get that HIV test. Talk to them about why it's important. And then anytime someone gets tested for any other STI, they should get tested for HIV. One of the biggest things that I see and that I do a lot of education in clinic in is when they say, I want STD testing, or I went somewhere and got STD testing, I'm like, well, what did you get? And they're like, well, I got STD testing. What does that mean? I got STD testing. That means nothing to me. Did they take your urine? Did they take their blood? What did they test you for? Because a lot of us, including adults, don't understand that you can't test for all STDs through one drop of blood or through one urine sample. Sometimes you got to get samples from the mouth or from the behind. And so it's important to ask providers, or to teach your young people to ask providers, hey, am I getting tested for gonorrhea, chlamydia, syphilis, HIV, herpes? What am I getting tested for? And then you can see that all women should be getting tested for chlamydia and gonorrhea. Yes. And so let me pause there. Yes, I'm gonna pause there and just put you at the back. Oh, I didn't do HPV vaccine. Let me do that. HPV vaccine. If it hasn't been said to you, I will be the pediatrician that says it. We are not giving this vaccine because 11 and 12-year-olds are having sex. That's not why we give it at age 11 and 12. We give the HPV vaccine at age 11 and 12 because we're hoping to get it into the children before they have sex. Because once you have sex, that's when you're exposed to HPV. Even though the cervical cancer, the oral cancer, the anal cancer doesn't come until later, or the warts don't come until much later, you're exposed to it at a younger age. And there's a lot of medicine that I'm not going to go into in this talk about it, but that's why we recommend it at age 11 and 12. It has nothing to do with the fact that we think 11, 12-year-olds are having sex, or that we what else do I hear? That we are trying to take away the fertility or things like that. It doesn't have anything to do with that. It's just we're trying to get it into them well before they have sex. And when you want to look to see if it works, it works. We'll just say that, including with oral cancers. And then this is it working with other types of cancers as well, which is what these things are showing. Okay, I'm gonna pause.
Okay, we are at time. So you have given us so much good information. It looks like you're giving us places to seek care here. So this has just been such a great talk. I appreciate, you talking about the different racial disparities that are out there and some of the reasons that we see those disparities. It's not because any racial group is more or less likely to get an STI. It's because we're not serving those people and we're not reaching those different racial groups in the way that we need to because of our own biases and stigmas. And there's also systemic things, of course, that go into that as well. So I appreciate everything that you talked to us about today. Are there any questions before we hop off of here? if anybody wants to come off mute. Thanks, Ivory, for joining us.
Ivory.
I'm so glad that you were here with us as well. We have this free webinar at the second Tuesday of every month. Dr. Hill won't be with us next month, but I imagine that the folks will want her to come back because this has been so informative and we didn't get to everything. So yeah, this is her contact information here. I'm just going to put another plug that I put the evaluation form in the chat. Please click on that and fill it out. It's just a couple of questions. I can give that feedback to Dr. Hill, and it also just helps us to do this better every month. I'm not seeing anyone come off mute. Kelsey, thank you. It says thank you to Dr. Hill. Yes.
You're welcome.
Awesome. Well, with that, Dr. Hill, any closing words?
You know, what I would say is, you know, keep being the amazing advocates that you are, or even if you feel like you're not an advocate, advocacy starts somewhere. So it's one step at a time. And always ask questions. That's what I do. If you don't know something, ask the question, and start having conversations with young people, regardless of how you relate to the young people.
Awesome. Thank you, Dr. Hill. Thank you everyone for joining us, and we will hopefully see you next month. Bye, everyone.